Question 1. A 44-year-old male with a history of COPD is severely hypoxic. The optimal way to administer high-concentration oxygen to him in the pre-hospital setting while monitoring for ventilatory drive issues is through which device?
A.
Nasal cannula at 6 liters per minute.
B.
Simple face mask at 10 liters per minute.
C.
Non-rebreather mask at 15 liters per minute.
D.
Venturi mask set to deliver 28% oxygen. Answer: C. Non-rebreather mask at 15 liters per minute. The concept being tested here is the management of severe hypoxia, especially in patients with chronic obstructive pulmonary disease. The keyword is severely hypoxic, which indicates an immediate need for maximum oxygen delivery regardless of the underlying lung condition, and the non-rebreather mask, NREMT, at 10 to 15 liters per minute provides the highest concentration of supplemental oxygen, up to 90%. While historically there was concern about suppressing the ventilatory drive in COPD patients with high-flow oxygen, current guidelines prioritize treating life-threatening hypoxia first. A practical example is that if a patient's SpO2 is below 90%, the priority is to correct the oxygen deficit before worrying about minor changes in their breathing drive. Remember this simple rule: treat the hypoxia first with an NRB, especially when the condition is severe, and monitor the patient's respiratory status closely. Question 2. A 62-year-old male is experiencing crushing substernal chest pain. He states he takes an erectile dysfunction medication daily. Which drug commonly administered by EMTs may be absolutely contraindicated in this patient?
A.
Aspirin.
B.
Acetaminophen.
C.
Oral glucose.
D.
Nitroglycerin. Answer: D. Nitroglycerin. This question tests the EMT's knowledge of nitroglycerin contraindications, particularly the interaction with phosphodiesterase inhibitors, commonly used for erectile dysfunction. The keywords crushing substernal chest pain point toward a cardiac event, and erectile dysfunction medication is the crucial contraindication clue. Nitroglycerin causes systemic vasodilation, meaning it widens blood vessels, which can lead to a drastic and dangerous drop in blood pressure when combined with certain medications like sildenafil, Viagra, or tadalafil, Cialis. For example, administering nitroglycerin within 24 to 72 hours of taking these drugs can result in life-threatening hypotension or low blood pressure. Always remember to specifically ask cardiac chest pain patients about recent use of erectile dysfunction medications before administering nitroglycerin. Question 3. During the primary assessment of a trauma patient who fell 20 feet, the EMT observes clear fluid leaking from the patient's nose and ears. The most appropriate immediate action regarding spinal stabilization is:
A.
fully immobilize the patient on a long backboard.
B.
apply a cervical collar and maintain manual inline stabilization, MILS.
C.
log roll the patient to assess the back for deformities.
D.
immediately place sandbags on either side of the head. Answer: B. apply a cervical collar and maintain manual inline stabilization, MILS. This scenario is testing the current standard of care regarding spinal motion restriction, SMR, in trauma patients. The clue, clear fluid leaking, suggests a potential basilar skull fracture and severe head/spinal injury, while the keyword, most appropriate immediate action, focuses on the primary assessment. Current guidelines recommend spinal motion restriction instead of rigid immobilization, starting with manual inline stabilization, MILS, and then applying a correctly sized cervical collar, as prolonged use of rigid backboards can cause complications like pressure sores and respiratory compromise. In a practical sense, the goal is to prevent the patient's head from moving, but unnecessary or prolonged full immobilization is avoided unless absolutely required for transport or extrication. Your takeaway is that MILS plus a C-collar is the baseline for suspected spinal injuries, keeping the spine in a neutral position. Question 4. A 28-year-old patient who takes insulin is found unresponsive. The patient's skin is pale, cool, and diaphoretic, and the breathing is shallow but normal in rate. The most likely immediate underlying problem is
A.
diabetic ketoacidosis,
B.
hyperglycemic hyperosmolar state, H.
C.
hypoglycemia,
D.
sepsis. Answer: C. Hypoglycemia. The concept tested is the immediate differentiation of diabetic emergencies based on physical signs. The keywords pale, cool, and diaphoretic, sweaty, are the classic triad for a sudden, severe drop in blood sugar or hypoglycemia, which causes the body's sympathetic nervous system to release epinephrine, adrenaline. Hypoglycemia has a rapid onset and presents with shock-like symptoms, whereas high blood sugar conditions like DKA or HHS typically present with warm, dry skin and a slower, more gradual decline in mental status. For example, a patient who took their insulin but skipped a meal will develop these symptoms quickly and may be treated immediately with oral glucose if they are conscious and can swallow safely. A quick tip: a cool and clammy diabetic patient needs sugar in the tummy or 4-glucose if advanced care is needed. Question 5. You are the first arriving unit at a mass casualty incident, MCI, and begin triaging patients using the START method. A patient is found to be breathing spontaneously after repositioning their airway, but remains unresponsive. This patient should immediately be tagged as
A.
red immediate,
B.
yellow delayed,
C.
green minor,
D.
black decisive. Answer: A. red immediate. This question tests the application of the simple triage and rapid treatment START method, focusing on the critical first step of airway assessment. The keyword, breathing spontaneously after repositioning, indicates an immediate, life-threatening airway compromise that was corrected by a simple maneuver, but the patient remains unresponsive. Any patient who requires a simple airway maneuver to begin breathing is placed in the immediate, or red, category because they are unstable and require constant monitoring and immediate transport for definitive care. For instance, if you perform a jaw thrust and the patient starts breathing, that patient is tagged red before moving on to assess their respirations, perfusion, and mental status. The core guideline here is that a corrected life threat remains a top priority and earns a red tag. Question 6. When assessing an infant or small child, the preferred method for assessing circulation and skin condition, especially for early signs of shock, is to check
A.
the carotid pulse,
B.
capillary refill time,
C.
the brachial pulse,
D.
the femoral pulse. Answer: B. capillary refill time. This question centers on the critical anatomical and physiological differences in pediatric assessment. The keyword infant or small child is the crucial clue, as peripheral vasoconstriction, narrowing of blood vessels, occurs quickly in children to compensate for blood loss or shock. Capillary refill time is the most sensitive and earliest indicator of poor peripheral perfusion, which is the movement of blood to the tissues, in a young child or infant, unlike adults where the skin condition is less reliable. For example, in a dehydrated infant, the capillary refill time will be prolonged, taking more than 2 seconds to return to normal color after pressing on a finger or the sternum. Remember that cap refill is a fast, reliable assessment tool for checking circulation status in young pediatric patients. Question 7. You respond to a 78-year-old male who is alert and oriented but insists on refusing transport after falling from a chair, despite having a visible deformity to his wrist. Before accepting the refusal, the EMT must ensure the patient has
A.
signed a witnessed refusal of care form,
B.
been examined by a physician via telemedicine,
C.
been informed of the potential risks, consequences, and alternatives,
D.
been given adequate pain medication for his injury. Answer: C. Been informed of the potential risks, consequences, and alternatives. The legal concept being tested is informed refusal, which dictates the necessary steps to protect both the patient and the care provider when a patient declines treatment. The key word is refusing transport, and the fact that the patient is alert and oriented confirms they have the requisite decision-making capacity. Informed refusal requires that the patient fully understands the nature of their illness or injury, the risks of refusing treatment and transport such as permanent disability or death, and the available alternative options, like a family member driving them to the hospital. A practical example is clearly stating, if you don't let us take you to the hospital, your broken wrist could become permanently damaged, and you could have continued pain. The takeaway is that a refusal is only legally valid if it is an informed refusal, meaning the patient understands the gravity of their choice. Question 8. An EMT is called to an unconscious patient who appears to have overdosed on an opioid. After confirming respiratory depression and achieving a patent airway, what is the most appropriate next step for the EMT, assuming local protocols allow it?
A.
Immediately administer 2 milligrams of naloxone intramuscularly, IM.
B.
Administer 1 milligram of epinephrine auto-injector, APPEN.
C.
Administer high-flow oxygen via a non-rebreather mask only.
D.
Begin chest compressions at a rate of 100 to 120 compressions per minute. Answer. A. Immediately administer 2 milligrams of naloxone intramuscularly, IM. This question assesses the EMT's understanding of opioid overdose management and the proper use of naloxone. The key phrase, opioid overdose combined with unconscious patient and respiratory depression, indicates the immediate need for an opioid antagonist to reverse the life-threatening respiratory failure. Naloxone directly reverses the effects of the opioid, often restoring spontaneous breathing, making it a critical, life-saving intervention that falls within the EMT scope in most current protocols. For example, while oxygen is vital, it cannot reverse the actual cause of the respiratory depression, which requires the administration of naloxone to bind to the opioid receptors in the brain. Your immediate tip is that in a suspected opioid overdose, the intervention is Narcan and the priority is to restore the patient's breathing. Question 9. A 30-year-old patient who had a generalized tonic-clonic seizure is now breathing normally, but remains unresponsive to verbal stimuli, and their muscles are completely flaccid. The EMT should recognize this as
A.
Status epilepticus.
B.
The aura phase.
C.
The postictal state.
D.
A transient ischemic attack. T. Answer. C. The postictal state. The concept being tested is the recognition of the typical phases of a generalized seizure. The key phrase is the patient is breathing normally but remains unresponsive immediately following the seizure, which defines the postictal state, or the recovery period where the brain is temporarily exhausted. Status epilepticus is defined as a seizure lasting longer than 5 minutes or consecutive seizures without a period of consciousness, while an aura is the warning phase before the seizure begins. For instance, in the postictal phase, patients often appear confused, drowsy, or unresponsive for a period of time, but their immediate life threats are typically over, unlike during the active seizure. The simple takeaway is that postictal means after the seizure and is the natural recovery period. Question 10. A 45-year-old male was involved in a motorcycle collision and is presenting with pale, cool, and clammy skin, tachycardia, and hypotension. Based on this presentation, the EMT should primarily suspect
A.
Neurogenic shock.
B.
Anaphylactic shock.
C.
Cardiogenic shock.
D.
Hypovolemic shock. Answer. D. Hypovolemic shock. This question tests the EMT's ability to differentiate the classic signs of the most common types of shock. The key elements, pale, cool, and clammy skin, tachycardia, fast heart rate, and hypotension, low blood pressure, are the body's compensatory mechanisms attempting to maintain core perfusion due to low circulating volume. Hypovolemic shock, caused by fluid or blood loss from the collision, is the most common form of shock following trauma, resulting in the sympathetic nervous system shunting blood away from the skin, thus the cool, clammy presentation. By contrast, neurogenic or anaphylactic shock would typically present with warm, dry skin due to blood vessel dilation. A practical example is that severe internal bleeding is causing the loss of volume, and the body reacts by tightening peripheral blood vessels and speeding up the heart. Your tip is that pale, cool, and clammy skin in a trauma patient usually indicates a volume problem. Question 11. An adult patient who is eating in a restaurant suddenly collapses while making a universal choking sign. After confirming unresponsiveness and inability to breathe, the EMT should begin
A.
5 back blows and 5 abdominal thrusts until the object is expelled.
B.
Chest compressions immediately, checking the airway before ventilations.
C.
A finger sweep to blindly locate and remove the obstruction.
D.
Rescue breaths after performing a head tilt chin lift maneuver. Answer. B. Chest compressions immediately, checking the airway before ventilations. This question assesses the management of a complete foreign body airway obstruction, FBAO, in an unresponsive adult. When an adult choking patient becomes unresponsive, the priority shifts immediately to chest compressions, similar to CPR, because chest compressions increase intrathoracic pressure, which may dislodge the object. The keyword collapses while making a universal choking sign confirms a severe FBAO, and confirming unresponsiveness dictates the change in protocol from standing maneuvers. For example, the sequence becomes 30 compressions. Open the mouth to look for the object, visualizing and removing it only if seen, and then attempt 2 ventilations. The takeaway is that once a choking patient becomes unconscious, manage them as a cardiac arrest patient with an airway check between compression cycles. Question 12. During positive pressure ventilation of an apneic adult with a bag valve mask, EMT should squeeze the bag.
A.
With enough force to cause visible chest rise.
B.
Slowly over 4 to 5 seconds to maximize oxygen absorption.
C.
Until the stomach begins to distend slightly.
D.
With the fastest possible rate to ensure saturation. Answer. A. With enough force to cause visible chest rise. This question addresses the basic mechanical principles and proper technique of using a bag valve mask. The keyword is positive pressure ventilation, which requires the EMT to deliver just enough volume to achieve effective oxygenation without causing complications. The correct method is to squeeze the bag only to the point of observing visible, equal chest rise, as overventilation, excessive volume, or speedy can lead to gastric distension, which increases the risk of the patient regurgitating and aspirating the stomach contents. A practical way to visualize this is to deliver a breath over about 1 second, watching the chest gently rise, and then allowing the chest to fall completely before the next breath. A helpful tip is that gentle chest rise is the absolute benchmark for adequate BVM ventilation. No more, no less. Question 13. Which of the following conditions is the only absolute contraindication for the administration of oral glucose by an EMT?
A.
Patient is currently taking insulin.
B.
Altered mental status with inability to swallow.
C.
Inability to protect their own airway.
D.
A blood glucose reading above 70 milligrams per deciliter. Answer. C. Inability to protect their own airway. This question tests the absolute rules for administering oral medications, specifically oral glucose. The concept is that any patient receiving an oral medication must be able to protect their own airway to prevent aspiration, inhaling the substance into the lungs. The key phrase, absolute contraindication, focuses the answer on a safety issue, and if the patient has an inability to protect their own airway, they are at risk of aspiration, which can be life-threatening. Even if a patient is hypoglycemic, if they are unresponsive or cannot swallow, they must not receive anything by mouth, and instead, advanced care must be called for 4-glucose or glucagon. The easy-to-remember rule for all oral medications is, if they cannot swallow or protect their airway, do not put anything in their mouth. Question 14. An 8-month-old infant is apneic and pulseless. EMT should recognize that in pediatric cardiac arrest, the most likely primary cause is
A.
primary cardiac dysrhythmia.
B.
Sudden cardiac death, SD.
C,
Uncorrected respiratory failure or shock.
D,
Trauma-related internal hemorrhage. Answer, C. Uncorrected respiratory failure or shock. The concept tested is the fundamental difference in the underlying cause of cardiac arrest between adults and children. In contrast to adults, where primary cardiac issues are the main cause, the keywords 8-month-old infant and cardiac arrest should clue you into the fact that the child's heart usually fails as a secondary event. Uncorrected respiratory problems like severe asthma or airway obstruction, or prolonged shock, like dehydration or blood loss, lead to hypoxia and acidosis, causing the heart to progressively slow down and eventually stop. For example, a child with severe dehydration from diarrhea might eventually experience cardiac arrest due to prolonged hypovolemic shock. Your key takeaway is, fix the breathing and circulation problems in a child, because that is what usually caused the heart to stop in the first place. Question 15. The EMT is assisting a woman in labor when the baby's head delivers. The EMT notes the umbilical cord is wrapped tightly around the baby's neck, nuchal cordae. The appropriate initial action is to
A,
immediately clamp and cut the cord before the shoulders deliver.
B,
Wait for the shoulders to deliver before attempting to unwrap the cord.
C,
Attempt to gently slip the cord over the baby's head.
D,
Apply firm pressure to the fundus of the uterus to speed up delivery. Answer, C. Attempt to gently slip the cord over the baby's head. This question assesses the necessary steps for managing a nuchal cord during a field delivery. The keyword, wrapped tightly around the baby's neck, signals a potential life-threatening complication that must be addressed immediately after the head delivers. The correct initial intervention is to try and gently slip the cord over the baby's head to prevent it from tightening as the shoulders deliver, which could occlude the baby's circulation or airway. Only if the cord cannot be slipped over the head should the EMT clamp the cord in 2 places and then cut it between the clamps before the shoulders deliver. Remember that trying to slip the cord over the head is the first and least invasive method to resolve a nuchal cord complication. Question 16. A 20-year-old male was struck in the head with a baseball bat and is now confused and complaining of a severe headache. The EMT should be highly suspicious of increased intracranial pressure, ICP, if the patient presents with
A,
hypotension, tachycardia, and bradypnea,
B,
hypertension, bradycardia, and irregular respirations,
C,
hypoglycemia, pupillary constriction, and confusion,
D,
pallor, restlessness, and narrow pulse pressure. Answer, B, hypertension, bradycardia, and irregular respirations. This question tests the recognition of Cushing's triad, a late sign of dangerously increased intracranial pressure, IC. The keyword, increased intracranial pressure, ICP, and the trauma scenario point directly to this critical set of findings. Cushing's triad is characterized by an increase in systolic blood pressure, hypertension, a decrease in heart rate, bradycardia, and an irregular pattern of breathing, which is the body's compensatory mechanism trying to maintain perfusion to the brain. For instance, the combination of high blood pressure and a slow heart rate is a classic, ominous sign that the patient's brain is being critically compressed. Your takeaway is that hypertension, bradycardia, and irregular breathing mean a high-pressure situation in the patient's head. Question 17. The primary goal of a primary assessment following scene size-up and BSI/PP is to
A,
obtain a complete set of baseline vital signs,
B,
perform a rapid head-to-toe examination,
C,
identify and correct all life-threatening conditions,
D,
determine the patient's chief complaint. Answer, C. Identify and correct all life-threatening conditions. This question focuses on the central priority of all pre-hospital patient assessment models. The keyword primary goal and the context of the primary assessment emphasize the immediate need to stabilize the patient before moving on to less urgent care. The entire primary assessment process, ABCD or CAB is a rapid, systematic search for any immediate threat to life, such as an occluded airway, inadequate breathing, or uncontrolled bleeding. For example, if you find a patient is not breathing, you correct that by starting ventilations before you even check their blood pressure or ask about their chief complaint. Always remember that the primary assessment is only complete once all immediate, correctable life threats have been found and managed. Question 18. An EMT is ventilating a patient with an endotracheal tube and notices the capnography reading suddenly drops from 40 millimeters of mercury
to 0
millimeters of mercury. Assuming the capnography unit is working correctly, the most likely cause is
A.
Improvement in the patient's metabolic state.
B.
A sudden drop in cardiac output.
C.
The endotracheal tube has been dislodged.
D.
Increased lung compliance. Answer: C. The endotracheal tube has been dislodged. This tricky question tests the interpretation of capnography, a vital assessment tool in advanced airway management. The concept is that the end-tidal carbon dioxide reading, EtCO2, reflects the CO2 being exhaled from the lungs, so a reading suddenly dropping from a normal value of 40 millimeters of mercury
to 0
millimeters of mercury indicates a catastrophic loss of ventilation. The most likely, immediate cause of this sudden drop is that the endotracheal tube has been completely dislodged from the trachea and is no longer ventilating the lungs. While a sudden, severe drop in cardiac output could cause a low reading, a reading of
0
millimeters of mercury typically means the tube is out or completely blocked, which is a life-threatening airway emergency. The key takeaway is that an EtCO2 reading of 0 means the patient is not breathing out CO2, which strongly suggests a misplaced or obstructed tube. Question 19. The EMT uses the Cincinnati Pre-Hospital Stroke Scale, CPSS, to assess a 55-year-old male. A positive finding that is necessary to complete this scale includes
A.
Pupil equality and reactivity.
B.
Facial droop, arm drift, and abnormal speech.
C.
Bilateral grip strength and gait analysis.
D.
Blood glucose level and heart rhythm. Answer: B. Facial droop, arm drift, and abnormal speech. This question tests the specific components of the Cincinnati Pre-Hospital Stroke Scale, CPSS, a standardized assessment for rapidly identifying a stroke. The scale is based on 3 easy-to-test and highly predictive signs of an acute stroke. Facial droop, ask the patient to smile. Arm drift, ask the patient to hold both arms out with palms up. And abnormal speech, ask the patient to say a simple, standard phrase. If any one of these 3 signs is present, the CPSS is considered positive, and the patient is highly likely to be experiencing a stroke. The CPSS is an essential tool for time-critical decision-making, as patients with a positive finding need rapid transport to a stroke center. Always remember the 3 components of the CPSS: face, arms, and speech, which are simple and fast to assess. Question 20. Which of the following patients is the only one for whom an EMT may administer their prescribed standing dose of a nebulized beta-agonist medication like albuterol, without direct consultation with medical direction?
A.
A 3-year-old in severe respiratory distress with no previous asthma history.
B.
A 65-year-old patient complaining of wheezing and dyspnea after an allergic reaction.
C.
A 40-year-old patient who has a standing order for albuterol and is exhibiting signs of bronchospasm.
D.
A 25-year-old patient with an expired albuterol inhaler. Answer: C. A 40-year-old patient who has a standing order for albuterol and is exhibiting signs of bronchospasm. The concept tested here is the scope of practice and the legal authorization for administering medications as an EMT. The key word is without direct consultation, which points to the use of a standing order, a specific pre-approved protocol set by the medical director. An EMT can administer a patient's own currently prescribed, and unexpired medication like albuterol for bronchospasm, if their local protocol includes a standing order that explicitly allows for this action under specific clinical circumstances. The other options involve either no prior diagnosis, a different primary problem, allergic reaction, though albuterol may be appropriate after medical control consultation, or an expired medication which requires additional steps or medical direction. The key takeaway is that standing orders give the EMT the necessary authorization to treat a pre-existing condition immediately without delay. Question 21. A 35-year-old male overdosed on narcotics and is now apneic. After successfully opening the airway with a head tilt, chin lift, the EMT finds that positive pressure ventilation is difficult to achieve. The most appropriate next step would be to
A.
Increase the force of the bag valve mask, B. Ventilation,
B.
Reevaluate the airway positioning and suction, if needed,
C.
Immediately perform a cricothyroidotomy,
D.
Insert a nasopharyngeal airway, NP. Answer: B. Reevaluate the airway positioning and suction, if needed. This question tests the systematic approach to managing an airway that is difficult to ventilate. The concept is that difficulty ventilating often means an issue with the patent, open airway, even after the initial maneuver. The key phrase difficult to achieve indicates that before escalating to more advanced or invasive steps, the EMT must first recheck the basics, such as the position of the head, the seal of the mask, or whether secretions or foreign material are obstructing the pharynx, which would necessitate suctioning. For example, if the head is not fully tilted back, the tongue may still be blocking the airway, requiring a slight adjustment. The easy rule to remember is, if you can't ventilate, you must first check for obstruction and reposition before trying anything else. Question 22. Which of the following findings would be a definite contraindication for inserting a nasopharyngeal airway, NP?
A.
An unresponsive patient with an intact gag reflex.
B.
Clear fluid leaking from the patient's nose.
C.
A patient who is actively vomiting.
D.
An oral injury that prevents insertion of an OPA. Answer: B. Clear fluid leaking from the patient's nose. This question is designed to test a crucial safety contraindication for the nasopharyngeal airway, NP. The concept is that an NPA should never be placed in a patient with a suspected basilar skull fracture. The key clue, clear fluid leaking from the patient's nose, suggests a potential leakage of cerebrospinal fluid, CSF, which indicates a severe head injury and an opening in the base of the skull. Inserting an NPA in this situation creates the risk of forcing the device into the cranial vault, brain, which is a catastrophic complication. A patient with an intact gag reflex or an oral injury are indications for an NPA, not contraindications. Always remember that any suspicion of a severe head injury or facial trauma that affects the base of the skull means you must not use an NPA. Question 23. You are assessing an 80-year-old female who is responsive to verbal stimuli and complaining of general weakness. During your primary assessment, you note that she is not wearing a medical alert bracelet or necklace. You should next:
A.
Ask the patient about any known medical conditions and medications.
B.
Immediately check the patient's blood pressure and pulse.
C.
Perform a rapid head-to-toe trauma assessment.
D.
Administer high-flow oxygen via a non-rebreather mask. Answer: A. Ask the patient about any known medical conditions and medications. This question tests the correct sequence of assessment, particularly the secondary assessment in a responsive medical patient. The key phrase responsive to verbal stimuli in a medical context indicates that the patient can provide information, which is gathered during the history-taking portion of the secondary assessment, the S in sample history. After completing the primary assessment and treating life threats, the EMT should ask the patient about their chief complaint, signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to the illness. A practical example is that the patient's statement, "I forgot to take my heart medication," or "I am diabetic" immediately directs the rest of your assessment and treatment. The takeaway is that a responsive patient is your best source of history and information, so ask them questions as soon as life threats are addressed. Question 24. A 2-year-old male child has a suspected complete airway obstruction. After positioning, you are unable to achieve a chest rise when attempting a ventilation. The appropriate action is to
A.
Immediately begin 5 abdominal thrusts.
B.
Administer 5 back blows, then 5 chest thrusts.
C.
Begin chest compressions.
D.
Attempt a finger sweep to blindly remove the object. Answer: C. Begin chest compressions. This question tests the management protocol for a complete foreign body airway obstruction, FBAO, in a pediatric patient who is unresponsive. The critical clue is the child is unresponsive and you are unable to achieve a chest rise after attempting to ventilate, which is the sign of a complete obstruction. When a child becomes unresponsive during FBAO maneuvers, or if initial ventilation attempts fail, the protocol shifts to full CPR chest compressions, 30 compressions for a single rescuer, as this is the best way to generate pressure to dislodge the obstruction. Back blows and chest thrusts are for a conscious choking infant, while abdominal thrusts are for conscious choking children over 1 year old. But once the child is unconscious, the priority is circulation and compressions. Remember to follow the sequence. Try to ventilate. If no chest rise, begin compressions. Check the mouth for the object before each ventilation attempt. Question 25. A 60-year-old male patient with a chief complaint of difficulty breathing has been placed on a non-rebreather mask. Which of the following signs would best indicate that the oxygen is being administered correctly and effectively?
A.
The reservoir bag on the mask completely collapses with each inhalation.
B.
The oxygen flow meter is set to exactly 6 L/min, 6 liters per minute.
C.
The patient's pulse oximetry reading increases by at least 10%.
D.
The reservoir bag remains at least 2/3 inflated during inhalation. Answer: D. The reservoir bag remains at least 2/3 inflated during inhalation. This concept tests the EMT's practical skill in ensuring the proper function and efficacy of a non-rebreather mask, NREMT. The key clue is the proper function of the NREMT, which is designed to deliver a high concentration of oxygen by preventing the patient from rebreathing their exhaled air, CO2. For the mask to work correctly, the oxygen flow rate must be high enough, typically 10 L/min, 10 liters per minute, or higher, to keep the reservoir bag from collapsing completely when the patient takes a full breath, thus ensuring a steady supply of almost 100% oxygen is available. If the bag collapses, the patient is breathing room air, reducing the delivered oxygen concentration. The takeaway is that an inflated NREMT bag ensures the patient is getting the high concentration oxygen you intend to deliver. Question 26. When assessing a 25-year-old female patient complaining of generalized abdominal pain, what findings should alert the EMT to the possibility of a life-threatening ectopic pregnancy, even if the patient states she is not pregnant?
A.
Pain that is localized to the left upper quadrant.
B.
A history of prior cesarean sections.
C.
Signs of shock without obvious external bleeding.
D.
Severe pain radiating to the back that worsens when standing. Answer: C. Signs of shock without obvious external bleeding. This question tests the EMT's awareness of internal hemorrhage from specific gynecological emergencies. The concept being tested is that an ectopic pregnancy, where the fertilized egg implants outside the uterus, often in the fallopian tube, can rupture and cause massive, rapid, concealed internal bleeding. The key clue is signs of shock without obvious external bleeding in a female of childbearing age with abdominal pain, as the bleeding is occurring internally within the abdominal cavity. Since a ruptured ectopic pregnancy can be rapidly fatal from hypovolemic shock, even if the patient denies pregnancy, this combination of signs requires immediate, high-priority transport. Remember that unexplained shock in a female of childbearing age is a time-critical emergency until an ectopic pregnancy is ruled out at the hospital. Question 27. You are managing a large-scale motor vehicle collision with multiple patients, which system's primary purpose is to clearly define roles, responsibilities, and reporting channels to ensure organized and effective scene management.
A.
Simple triage and rapid treatment start.
B.
Incident Command System, ICE.
C.
Unified Command System, U.
D.
Hospital Emergency Incident Command System, HICS. Answer. B. Incident Command System, ISIS. This question tests the foundational operational concept for managing complex emergencies like a mass casualty incident, MCI. The keywords clearly define roles, responsibilities, and reporting channels are the definition of the Incident Command System, IC. ICS is a standardized management tool used for all risk, all hazard events that ensures clear lines of authority, limits the span of control, and utilizes common terminology across different agencies to create an organized, efficient, and adaptable scene structure. START is a triage method, not a management structure. The key takeaway is that ICS is the essential framework for bringing organization and structure to the chaos of a major emergency scene. Question 28. A 75-year-old male with a history of hypertension is found to be confused. His blood pressure is 200/110 mmHg, and his heart rate is 60 beats/min. 60 beats/min. The EMT should suspect
A.
hypoglycemia,
B.
an acute hypertensive crisis,
C.
hypovolemic shock,
D.
a tension pneumothorax. Answer. B. An acute hypertensive crisis. This question assesses the recognition of a dangerously elevated blood pressure reading. The keyword hypertension combined with the extreme blood pressure of 200/110
M.
200/110 mmHg, and the altered mental status indicates an acute hypertensive crisis, also known as hypertensive encephalopathy, where the extreme pressure is damaging the brain. This is a time-critical medical emergency, as sustained high pressure can lead to stroke, organ damage, or heart failure. Hypoglycemia would typically present with pale, cool skin and normal to fast heart rate, while shock would show hypotension. The simple tip here is that a blood pressure this high, especially with symptoms like confusion, requires urgent transport for advanced blood pressure management. Question 29. A construction worker has suffered an open femur fracture with severe, uncontrolled hemorrhage. After applying direct pressure and elevating the limb, the bleeding continues. The most appropriate next step for the EMT to control the bleeding is to
A.
apply a splint and rapid transport.
B.
Apply a tourniquet high and tight on the extremity.
C.
Pack the wound with hemostatic gauze and apply pressure.
D.
Apply pressure to the femoral pressure point. Answer. B. Apply a tourniquet high and tight on the extremity. This question tests the critical steps in controlling life-threatening extremity hemorrhage, reflecting modern trauma guidelines. The key phrase, severe, uncontrolled hemorrhage, indicates that standard direct pressure has failed, and the most effective and preferred next intervention is the rapid application of a tourniquet to the injured extremity. Current protocols prioritize the immediate and effective control of massive bleeding, and a properly applied tourniquet placed high on the limb and tightened until the bleeding stops is the definitive pre-hospital intervention for this type of injury. While packing with hemostatic gauze is an option for junctional wounds, a tourniquet is the fastest, easiest to apply, and most effective device for controlling severe extremity bleeding. Remember this simple mantra. For life-threatening extremity bleeding, if direct pressure fails, apply a tourniquet high and tight. Question 30. During a full-term delivery, the EMT notices a loop of the umbilical cord protruding from the vagina before the baby's head has delivered. This complication is known as
A.
placenta previa,
B.
Nuchal cord.
C,
Breech presentation.
D,
Prolapsed cord. Answer: D. Prolapsed cord. This question tests the recognition of a specific, life-threatening obstetrical emergency that requires immediate intervention. The key phrase is the umbilical cord protruding from the vagina before the baby's head has delivered, which precisely defines a prolapsed cord. A prolapsed cord is an emergency because the baby's head will compress the cord during delivery, cutting off the baby's oxygen supply, which can be fatal. This complication requires the EMT to immediately place their gloved fingers inside the vagina to lift the baby's presenting part off the cord to relieve the pressure, and then transport immediately. A prolapsed cord is an immediate time-critical situation that demands specific, immediate hands-on care. Question 31. What is the fundamental difference between anaphylaxis and a simple allergic reaction?
A,
Only anaphylaxis causes respiratory distress.
B,
Anaphylaxis involves two or more body systems or a severe respiratory/circulatory compromise.
C,
Only simple allergic reactions can be treated with an epinephrine auto-injector.
D,
Simple allergic reactions have a slower onset than anaphylaxis. Answer: B. Anaphylaxis involves two or more body systems or a severe respiratory/circulatory compromise. This question is designed to test the criteria used to differentiate a mild allergic reaction from a severe, life-threatening allergic reaction, which is anaphylaxis. The critical concept is that anaphylaxis is defined as a systemic reaction involving at least two body systems, like hives/skin and wheezing/respiratory, or a single life-threatening symptom such as severe respiratory distress or signs of shock/hypoperfusion. While a simple allergic reaction may cause localized symptoms like hives, anaphylaxis involves widespread, dangerous vasodilation and bronchoconstriction that can lead to shock and airway closure. For example, a patient with hives and wheezing is considered anaphylactic, whereas a patient with only hives is a mild reaction. The takeaway is that the involvement of multiple body systems or a sign of impending airway/circulatory collapse signifies anaphylaxis and the need for immediate epinephrine. Question 32. Which of the following is an example of an EMT fulfilling their ethical and legal responsibility when documenting a patient care report? P, sir?
A,
Writing in shorthand to save time.
B,
Correcting a documentation error by completely whiting out the mistake and writing over it.
C,
Subjectively stating that the patient was clearly intoxicated.
D,
Documenting a missed finding and a late treatment decision with a clear addendum. Answer:
D,
Documenting a missed finding and a late treatment decision with a clear addendum. This question tests the principles of proper, legal, and ethical documentation in pre-hospital care. The concept is that the patient care report, PCR, must be an accurate, objective, and complete reflection of the EMT's assessment and care, including any errors or deviations. Writing an addendum to acknowledge a missed finding and a late treatment decision demonstrates honesty and transparency, which is legally and ethically paramount in medical documentation. Conversely, using shorthand, using whiteout, or stating subjective opinions like clearly intoxicated are all considered improper and potentially illegal practices that compromise the integrity of the medical record. The key takeaway is that honest, factual, and complete documentation, even when detailing mistakes, is essential for patient care and legal protection. Question 33. A 68-year-old male with a history of congestive heart failure, CHF, is sitting upright, gasping for air, and has pink, frothy sputum at his mouth. The EMT should recognize these signs as classic for
A,
spontaneous pneumothorax,
B,
chronic bronchitis,
C,
acute pulmonary edema,
D,
pneumonia. Answer: C. Acute pulmonary edema. This question tests the recognition of the classic presentation of acute pulmonary edema, a life-threatening complication of heart failure. The key clues are the patient's history of congestive heart failure, CHF, gasping for air, severe respiratory distress, and the distinctive pink, frothy sputum. In heart failure, the left side of the heart is unable to pump efficiently, causing fluid to back up into the lungs and leak into the alveoli, resulting in the pink, foamy fluid at the mouth. A practical example is that the patient is essentially drowning in their own fluid, and this condition requires immediate positive pressure ventilation, if available. The rule of thumb for CHF patients is that pink, frothy sputum means immediate and severe fluid backup in the lungs. Question 34. A patient involved in a motor vehicle collision responds to pain by withdrawing the limb. Using the Glasgow Coma Scale, GCS, for motor response, how would the EMT score this finding?
A.
3. Flexion abnormal.
B.
4. Withdraws to pain.
C.
5. Localizes pain. D. 6. Obeys commands. Answer: B. 4. Withdraws to pain. This question is a direct test of the Glasgow Coma Scale, GCS, specifically the motor component. The keyword withdrawing the limb to a painful stimulus aligns exactly with a GCS motor score of 4. This motor response means the patient is moving their limb away from the stimulus without localizing the pain or flexing abnormally. For example, if you pinch the patient's nail bed and they pull their hand back from the stimulus, that is, withdraws to pain, which is a better response than abnormal flexion but worse than pinpointing the source of the pain localizes. Memorize the GCS motor scale. 6. Obeys. 5. Localizes. 4. Withdraws. 3. Abnormal flexion. 2. Abnormal extension. And 1. None. Question 35. A 28-year-old female is experiencing a severe allergic reaction after being stung by a bee. She is unconscious, with widespread urticaria, profound hypotension, and rapid, shallow breathing. The EMT's most immediate life-saving intervention, following the primary assessment, should be to
A.
Administer oral Benadryl.
B.
Perform a rapid head-to-toe assessment.
C.
Administer the epinephrine autoinjector.
D.
Apply a cold compress to the sting site. Answer: C. Administer the epinephrine autoinjector. This question tests the recognition and immediate treatment priority for life-threatening anaphylactic shock. The keywords unconscious, profound hypotension, shock, and rapid, shallow breathing signify a severe, rapidly decompensating anaphylactic reaction. Epinephrine is the primary, life-saving medication for anaphylaxis because it simultaneously reverses the two main problems. It is a vasoconstrictor that raises blood pressure and a bronchodilator that opens the airways. All other options are either too slow Benadryl, not the priority assessment, or ineffective for systemic shock, cold compress. The absolute rule is that any sign of systemic shock or severe respiratory distress during an allergic reaction warrants the immediate administration of epinephrine.